I think this is a very important topic. What the endocrinologist should know about assays. Previously we used to have radio immunoassays. That's going off. Now we have the CLIA, chemiluminescence, and then now we are actually moving on to LCMS. So what are the advantage of this CLIA versus that of LCMS, or LCMS will supersede all these assays? Is there a role for the, I think these are the aspects also, I think, speaking. Of course, what are the factors? How do you do, what are the interferences which can happen? How do you tackle that? So these are the things I think Dr. Rana will be addressing. Go to Dr. Rana for the proceedings. I hope nobody is using two phones, no?
Possibly, yes. There is some kind of echo there.
Echo, that's why.
Yeah. I'm Niladri. When I'm trying to share, I'm getting a message that host disabled participant screen sharing. So I think you need to allow it. Nilanjana? Yeah. I think you need to allow it from your end, from the host's end. Otherwise, I can't share mine.
Means you have to make Rana sir either the host or the co-host. That only Niladri will be able to do because you are the host.
Okay. So let's Niladri. Yeah. Fine. Now it's there.
सही लगे ना उत्तम बहुत दिन बाद खाए तो
I think the slides are visible now. Yeah. Okay.
Yes, they're visible.
Yeah. Thank you, Professor Bantwal, for the nice introduction of this topic. And thank you, Nilanjana, and thank the organizing committee of this 4E webinar for this topic, which is, I think, is a very practical kind of topic. And the hormone assays, what we need in our day-to-day clinical practice, day in and day out. And there are many factors, there are many issues which we need to deal with while we're ordering some tests and interpreting the same. Now, over the last 7-8 years, I'm overseeing the hormone assay lab of our department. And but I felt that it's really important that you must have a connection or must have a liaison with your lab whenever you have any kind of doubt regarding the results, and particularly for the trainees, how to process and how to send the samples. That are also, that is a very much, I mean, it's a very, very important part regarding this particular assay that you are ordering. So practice in clinical endocrinology, as you know, is highly dependent on an accurate laboratory assessments. And many a time the lab tests are even more sensitive than the clinical examination or clinical history technique. So in some situation, it has an immense importance, and in many other situations, it helps to corroborate our clinical finding, and our treatment decisions that depend on these values that we get from the lab. And for follow-up of the patient, again, the different kinds of assays are very, very important. So it's very important to know about the capacity and various pitfalls of the lab methods, particularly when there is discrepancy between the result and the clinical feature. Bioassays are nowadays very rarely used for the clinical practice. They're used in some research setting, but nowadays the most two different assays which are used most commonly are immunoassays, and second is structure and the charge-based assays. Now we are most conversant with the first, so I'll discuss these in detail. But as the structure and charge-based assays are becoming more and more popular even in our country. So I will discuss a brief overview of that with just 3 or 4 slides. But again, my main focus would be on different kind of immunoassays. Now, immunoassays are basically based on the antigen-antibody reaction, as the name suggests. And the journey started with these two legendary persons, Rosalind Yellow and Solomon Burson. They developed radioimmunoassay in their laboratory at Bronx in New York City. And for that, Rosalind Yellow got a Nobel Prize, but unfortunately, before the announcement, Solomon Burson died. So it's not given posthumously. So she was the only recipient, Rosalind Yellow was the only recipient of this particular Nobel Prize, medicine. Regarding the various components of immunoassay, one important part is analyte. It's nothing but the name of the molecule that you want to measure. Then comes the antibody. There are various kinds of antibodies that are used in the different assays. One is polyclonal, where the antibodies are derived by immunizing the animals like rat with the antigen, that is the hormone that is intended to be assayed, and from the blood, the antibodies are separated. And as you can well imagine, that as the antibodies are produced by different kinds of B cells, different clones of B cells, so they work on different antigen epitope of the same hormone. But the problem is the yield of this is very small. So we need a large amount of antibodies to run so many laboratories worldwide. So for that, the monoclonal antibody system has been developed. This is the way the monoclonal antibody is formed. This is important when we discuss some interaction like anti-animal antibodies. So here the animals are injected with the antigen, and the spleen cells are harvested and they are fused with the myeloma cells, and they're cultured together, and a large amount of antibody is produced. And as from the spleens and myeloma cells are fused, so only one clone of cell produces that antibody. So this antibody is specific to a particular epitope of an antigen. The potential problem with that is that some hormones can have different forms of different forms which have biologic activities, but the antigen binding epitope may differ between one molecule and the other. So sometimes the monoclonal antibody detects less amount of the hormone. Sometimes it even cannot be able to, or won't be able to detect the hormone itself, because that particular epitope may not be present of the particular hormone of that particular person. So to overcome this, nowadays the engineered polyclonal antibodies are also used, where the different kinds of monoclonal antibodies mixed together. So it mimics the polyclonal antibody, but the yield is much more, as the monoclonal technique is used for it. Now, either analog or antibodies, depending on various assay systems, are labeled with various kind of tracers, and they are detected depending on this tracer molecule. They can be detected by various kinds of sensors. Now, depending on this tracer and detection technique, we classify the immunoassays. So whenever the radioisotope is used, we call it RIA or radioimmunoassay. When colorimetry principle is used, we call this ELISA, which can be manual, automated, or even semi-automated. We can use direct fluorometry. So immunofluorescent assays, they are called. You have also heard about Delphia. which is used, say, for example, in a heel prick sample TSH measurement. So this is a variant of fluorescent assay where the signal generation is artificially delayed so that background noise can be avoided. And most commonly used technique is chemiluminescence or its variants, electrochemiluminescence, where the light signal is emitted, and depending on the intensity of light signal, the sensor can detect the amount of analyte within a sample after the antibody antigen reaction. So I will talk about this in detail later on. There are some important terminologies which you need to remember. You may have come across terms like closed versus open system. An open system is nothing but an assay system where you can use the kit of many manufacturers. But in closed system, the kits are produced by a particular manufacturer who manufactures a machine, and the assays are also validated mostly by them. There is another term that is homogeneous or heterogeneous assays. The homogeneous assay is also known as simultaneous, or a heterogeneous assay is also known as sequential. This is nothing but the in assays where a washing step is used, that is called sequential, but where the antigen antibody reaction and the enzymatic or chemiluminescent reaction is done within a same assay system without the need for separation is called homogeneous assay system. And immunometric and competitive immunoassay is very, very important. I will discuss this in my next few slides. So talking about the immunometric assay, this assay is also known as sandwich assay. Now, what are the principles of this assay? I will discuss this with an example which is used in a particular machine that Immunolite 1000 that we use in our lab. This is a particular test unit. This is an example. This is an HCG test unit. Now, let me show you. I think this is visible. This is a typical test unit that we use in our lab. So here you can see there is kind of a chamber within which there is a bead. So this bead is depicted here. This is actually the solid matrix, and upon which, as this is an HCG test unit, the anti-HCG antibodies are attached to this particular bead. Then the reagent is added on that, and the reagent contains anti-HCG antibody which are labeled with alkaline phosphatase. And this antibody and the antibody which are there in the solid matrix, they bind two different epitopes of a particular hormone. So you can well imagine this is not useful for steroid hormone assay. This is used for peptide hormone assay, as you need two different epitopes for this kind of reaction to occur. So after this, the sample is added. So this is the patient's serum, which contains a certain amount of HCG which we intend to measure. Now this is incubated, and HCG molecule that in patient serum gets sandwiched between the anti-HCG present on the solid matrix, that is the bead, and the anti-HCG that is tagged with alkaline phosphatase. And then it is washed. Now, as you can see, the water or the washing buffer rather is added to this, and it is rotated in a very high speed, and with the rotation due to centrifugal force, the fluid goes up and gets deposited in the chamber, and with the subsequent then the substrate is added after the washing, and the substrate contains a molecule known as adamantyl diopsitine phosphate. Now this particular molecule, when it is acted upon by the alkaline phosphatase, depending on the which is attached to the anti-HCG antibody, it breaks down this and forms a substance which is luminescent. So that's why, as it is chemically split and luminescence is formed, that's why it's called the chemiluminescence assay. And ultimately, the bead it glows, and the amount of light that is emitted by the bead, it is measured by the sensor. So as you can well imagine, the more the amount of HCG in the sample, more is the binding, and more amount of this photo emitting substance is generated, and therefore the luminosity is more. So if we look at the dose response curves, so this is the typical dose response curve of a sandwich assay. So with increasing antigen concentration, the intensity of signal also gets higher. So this is the principle of immunometric or sandwich assay. Now, what is competitive immunoassay? Here, the same kind of kit is used, but I've used the T4 as an example, as T4 is a small steroid-like molecule. So steroid and steroid-like molecules are mainly measured by competitive immunoassay nowadays, although it can also be used to measure the peptide hormones as well. But as the sandwich assays are more sensitive, so we do not use competitive immunoassay for peptide hormones nowadays. So here, the important thing is that the bead is coated with anti-T4 antibody, but unlike anti-HCG antibody that I shown in previous example, here the binding sites are very limited in number, so that the competition can be generated between the patient sample and the tagged hormone analog. So that's why the number of sites on this bead is limited. So again, just like sandwich assay, here the T4, which is labeled with alkaline phosphatase, is added to this, and subsequently it is incubated, and it is after washing by the same methods. Again, the substrate is added and the light signal is generated. But now, as there is a limited number of binding site on this solid matrix, the patient's T4 and the reagent that is there, that is T4, which is tagged with the alkaline phosphatase, they compete for this binding. So as you can well imagine that the higher the amount of T4, less will be the binding of this and the alkaline phosphatase tagged hormone analog or T4 analog. So higher the amount of T4, the generation of signal would be less. So the dose response curve will be just opposite to that we have seen with sandwich assay, that with increase within antigen concentration, the signal drops. So these are the principles of immunometric versus sandwich immunoassay. Now we'll focus on another important kind of assay, that is free hormone measurements. How to measure a free hormone. Now, this is just one of the examples. As you can see, the free hormones level, the concentrations are several orders less than the concentration of total hormones. So T4 concentration range versus free T4 range is widely different. So the assays are also more difficult. So the measurement of free hormone, as you all know, that it's based on the free hormone hypothesis, which states that free fraction of the hormone is actually responsible for biologic activity of that particular hormone at cellular level. But there are exceptions with this as well. As you know, as for example, with the testosterone, the free plus albumin bound fraction can be considered as bioactive. But again, that is not important for this discussion. What is important is that the methods by which we can assay this particular hormones, the free hormones. So one group, we call it direct method, that is equilibrium dialysis or ultrafiltration, or another group is called indirect estimate tests, which include the index method, among which like SHBG immunoassay, which we use to get a free testosterone index, is one of the example, or we can indirectly measure the free hormone levels by antigen antibody reaction. Among direct methods, those are very much labor intensive, so they are mainly used to generate the calibrator against which all the immunoassays are calibrated. So they are mainly used to assay the standard system. And other than this, the another use of this is when you get a doubtful result. If you have this facility, you can send the patient sample to get a more accurate measurement by these techniques. Now, this is one of the example of the dialysis method. So here a dialysis membrane is used for equilibrium dialysis, and it there is sometimes needed to get a proper balance between the two sides of the dialyzing chamber. And we can measure the free hormone from this compartment, which is dialyzed. The total hormones are not filtrated to this particular membrane. Now, what is ultrafiltration? It is nothing but to speed up the process of dialysis. A kind of certain kind of pressure is applied over this compartment, and the free hormones are filtered out, and they are usually measured by LCMS. But again, more commonly in immunoassays, we use another technique, the indirect technique. What is that? This is one of the example of two-step assay. Now here, the solid matrix is coated with the antibodies, just like the competitive immunoassay that I have discussed earlier. It is designed in such a way that it cannot bind to the hormone which is bound to their binding proteins. Like if it is an anti-T4 antibody, it cannot bind with total T4, that is the hormone, the T4 that is bound to either TBG or albumin or transthyretin, but it binds only with free hormone. So here a kind of labeled analog is used where it also binds with this particular antibody, but it does not bind with the binding protein. So for all practical purpose, there is a competition between the labeled analog and the free hormone that is there in the patient's serum. So principles are same as the T4 assay that I have discussed. So here, after this reaction, there is a wash, this particular assay system, a wash buffer is used, and then the amount of tagged hormone that is attached to the solid matrix bound antibody is measured. And you can well imagine, just similar to the competitive immunoassay, here also the generated signal is inversely proportional to the amount of hormone, free hormone, that is present in patient's analyte. So higher the amount of signal, lower is the amount of analyte present in the patient's serum. But what is more commonly used is a one-step method, where the initial washing, after, here you can see that after the first step, washing is used, and then it is back titrated with the label steroid. But here, the simultaneously, both the tagged analog and the patient's analyte is added to the system, and then it is washed. So the washing step is single, unlike the two-step wash in the previous method. So this is most commonly used in various clinical assay laboratory, including our assay system. So here also the principle is same, and the amount of analyte is inversely proportional to the signal generated. There is another method. This is mostly used in the research laboratories, where the solid matrix is coated with the hormone itself, and a tagged antibody is used, and these hormones in the solid phase and the free hormone in the liquid phase, they compete for the tagged antibody. So when after this reaction, this is of wash buffer is applied and the signal is measured, again the amount of signal generated is inversely proportional to the amount of free hormone, because higher the free hormone level, they bind more amount of tagged antibody and they are washed out after the subsequent buffer wash, and the less amount of antibody will be attached to the steroid or steroid-like molecules that are attached to the solid matrix. So again, here also, although the principle is a bit different, the outcome is similar, that the signal generated is inversely proportional to the concentration. Now, after discussing all these things, we'll discuss a few steps regarding the assay validations. We'll come across various terms while interpreting various assays. Now, this validation, it is applied mainly to the immunologic or immune-based assays, but it also can be applied to other kinds of assays as well. So these are the common terms that is used. One term is called sensitivity. So what is assay sensitivity? Please do not confuse this with a sensitivity of a test for detection of a disease. The assay sensitivity is a different thing. It means the amount of the analyte, the least amount of analyte that can be measured. So that is called assay sensitivity. Now, one is called the limit of detection. That means the minimum amount of analyte that can be detected by an assay system. And more importantly for us, there is another term called limit of quantitation, which is a bit higher than the limit of detection. This is a level at which we can measure level of an analyte confidently. So if you see a laboratory result, say if you see the cortisol level is less than 1 microgram per deciliter, that means the functional sensitivity of the assay or limit of quantitation of this assay is to 1 microgram per deciliter. It can detect even the lower concentration of cortisol, but it cannot reliably quantitate it. So it's very important to know this difference. What is precision? This is the value that is generated. You all know this is nothing but the coefficient of variation, that is standard deviation divided by mean. So precision can be measured between different assays or between different calibrations. What is specificity? It is the ability to detect a particular molecule when the related molecules are present in that particular sample, or degraded product of the analyte is present in the sample. Specificity can also be affected by various kinds of interference like lipemia or hemolysis. I will discuss that later on. But this specificity is very important. I will show you one of the example where the steroid, when you measure say cortisol, you must know that how much it cross reacts with other related molecules. So this specificity is very much related to cross reactivity, which I will discuss later on. What is accuracy? Accuracy means the performance of this assay related to the reference material. Okay, so this is another very important parameter to know, and depending on all these things, the test utility or robustness is determined, and ultimately, depending on all this, we interpret various things like what is reportable range, what is reference interval, and what is diagnostic power of the test. I won't go into detail of these things. If you're interested, we can discuss this at the end of the talk. Now, what is the difference between accuracy and precision? This is one of the things which is often confused, and this is a very commonly used diagram to clarify between these things. This assay, you can say it's accurate as well as precise. It is precise because all the values generated are very close to each other. And why it is accurate? Because in comparison to the standard assay system, the values are also closely similar. This particular assay is precise, but the results that is generated may not be similar to that of reference material. Now, if you have a particular value or during follow-up, if you have a particular patient for follow-up, then this kind of assay do not create a problem. Like if I give you an example, like when you measure thyroglobulin, now it's said that you need to measure for a follow-up, you need to measure it from a single lab, because you know the measurement that is measured in different labs may not be accurate because the process of standardization is not yet up to that mark that those assays may be accurate. But if they are precise enough, then a certain value that you get is useful for follow-up of this patient, or if you know the normative range for that particular machine, you can interpret the result for your clinical assay. But if it is imprecise, then this test is of no use. Now, with all this background in mind, let's discuss few of the pitfalls of different kinds of immunoassays. It's very important to know that most of the problem with a test result generates at the level which is pre-analytic. That is the patient identification, the labeling of a sample tube, how you are processing the sample, how you are transporting it to a lab. So you must remember that if you get a discrepant result, you shouldn't blame the laboratory straight away, because the other factors you need to take into account, and they are in fact responsible for most of the errors that we get in the assay result. But again, the analytic phase and post-analytic phase are also very important. So among the analytic phase, I will mainly focus today on the analysis itself, okay? Because of lack of time, I won't go into all the other things today. So among the analytic phase, one of the common problem that we come across is hook effect. I think most of you are aware of this, if not all of you have this term. So this usually occurs in one-step immunometric assays, which is commonly used in our clinical practice. Now, here what happens, if the amount of analyte is too high, is much higher than the antibodies that are bound to the solid phase, they actually can mop up all the tagged molecule, tagged analyte that is added to the assay system later on. And after wash, they can wash out all the tag level and the values can be lower. So you can see this is the capture antibody, this is the detector antibody, and the antibody and the analyte is sandwiched between them. But when the amount of this analyte is too high, the tagged antibody do not get an opportunity to bound to with this particular analyte. So the sandwich is not formed adequately. So you will get falsely low signal after this wash. So you can see in this particular example, if you have a value of 32,000 units of a particular test, due to this hook effect, you will get a value near 50. So you get a falsely low value when the concentration is very high. So due to this kind of dose response curve, this is called a hook effect. Okay. So how this problem can be mitigated? Nowadays, the assays, they use a very high amount of antibodies. As I've said, nowadays the generation of the antibody is monoclonal or engineered polyclonal. So large amount of antibody can be generated, and they are fixed to the solid matrix. And therefore, even with a very high concentration of analyte, there is adequate binding and measurement of the analyte in the sample. So usually, as for an example, in a Immunizate 1000 assay, the hook effect doesn't develop until the prolactin level is more than 22,000 nanogram per ml. So for all practical purpose, say in last few years experience, I haven't come across a single patient where I can confidently say that this is the patient where the hook effect was there. Okay. But again, still, if you suspect, particularly if there is a, say, a large tumor in the base of the brain, here you again should ask for sample dilution, because after dilution, say 1:5 or 1:10, the amount of analyte that is there in the matrix gets diluted and the hook effect can be mitigated. Or in some assay format, two steps are used. That is, after the first reaction, a wash buffer is used, and then subsequently the tagged antibody is attached to the matrix. So what happens? After this initial binding, as the wash buffer is applied, the unbound analyte, which is very high concentration, gets washed out. And if you add the tagged antibody on top of that, the hook effect is no longer there. But you cannot manipulate a closed system, which is most commonly used nowadays this way. So you have to rely upon the sample dilution where there is suspicion. Another problem that I have just said is the cross reactivity. Okay, and it is the problem is more with monoclonal antibody, the polyclonal antibody, particularly in the immunometric assays. So here what is one of the advantages of the monoclonal antibody. Just to give an example of the cortisol, this is the typical cross reactivity data that is there from our assay system of Immunizate 1000. That is, it is generated by a technique known as spiking. And here, as you can see, this particular assay does not react significantly with aldosterone, androstenedione, betamethasone, and most of the assays are insensitive to dexamethasone, and that's why we use dexamethasone suppression test for a practical clinical purpose. It also does not react significantly with molecules like 11-deoxycortisol and 11-deoxycorticosterol. So in a patient with, say, 21-alpha-hydroxylase deficiency, the chance of getting falsely high cortisol result is very less with Immunizate 1000. But this cross-reactivity may be higher with other assays. So these are the very important parameters to remember. And if you focus on prednisolone, you can see it has around 50% of cross-reactivity with this cortisol. So it's very important to know when you get a particular result, you must ensure the patient has stopped taking cortisol or hydrocortisone, say 24 hours before the drawing of the sample. Okay, so this is all about cross-reactivity. The another term that is used is called interference. In some literature, the cross-reactivity is included within the interference, but most of the literature say the interference is something where the parallelism between the analyte and the cross reactant is not there. That is called interference. Where in cross reactivity, there is some kind of parallelism between the analyte and the cross reactant. Now here, the various factors can interfere with antibody binding, signal generation, or signal detection. And there are different kinds of interferences. One that can alter the measurable analyte concentration in the sample, like presence of different hormone binding protein, as for example, the dysalbuminemic euthyroid hyperthyroxanemia. So there, our instinct says that the total T4 level or total T3 level, depending on the mutation, will be high. But if you measure free hormone, we can measure this reliably. But no, due to the, as I have shown in the example, there is some kind of equilibrium that is generated between the matrix, the liquid, and the solid component during the antibody-antigen reaction. So if the binding proteins are abnormal, either in quantity or qualitatively, then we can get falsely high level of free hormones as well. So this is a kind of interference. There are many pre-analytic factors as well, like EDTA sample is not suitable for TSH assay. So this is one of the example. There are some autoanalyte antibodies, like anti-TG antibody, which can give rise to falsely low value of TG in immunometric assays. There can be some interference that can alter antibody binding. I will discuss few of that. One of them, as you all know, is called heterocycle antibodies. Those are usually produced by the person himself or herself. And these antibodies are very weakly, they can bind weakly to a wide range of analyte. So if they are present in a very high amount in the sample, they can interfere with various kinds of analytes. There are other autoantibodies as well, and human animal antibodies are specific to a particular animal, and it usually develops from exposure to, say, pets. Like if someone have a rabbit in their house, so they can develop antibody against various kinds of rabbit antigens, and the assay system which use the monoclonal antibody that is generated from the rabbit can give rise to this kind of interference. And there are some other interference which can be there due to alteration of signal generation. I will discuss those in just one slide. Macroprolactin is another kind of interference where the autoantibody, the IgG antibody, can bind multiple molecules of prolactin or TSH, which is biologically inactive, but due to the low filtration through kidney, can give a high value when you measure it by a particular assay. These are something that I have already covered, and pregnancy is one of the condition where again the free thyroid hormone test is again not reliable because of this binding hormone related interference. Autoantibody, I think I have covered all this. Heterocycle antibody, and one of the example of autoantibody which behaves like heterocycle antibody is IgM rheumatoid factor. Now, how this kind of heterocycle antibody interferes with the system? The kind of interference depends on the binding of this heterocycle antibody to various the different components of the analyte or the antibodies. Now, this is a typical sandwich reaction without interference. But if, say, as for example, there is no analyte in the sample, but heterocycle antibody is present, or even autoantibody, anti-animal antibody is present, they can bind both to the capture antibody as well as detection antibody to form a bridge. And thereby, despite the absence of analyte, the high amount of signal is generated, so you will get a false positive result. On the other hand, if that particular antibody, they bind in such a way to the capture antibody that there is steric hindrance of binding of analyte to the capture antibody. In this situation, even if the analyte is there in the sample, but the result will show a low value. So it will give a falsely low value. Now, how to deal with that? You can dilute the sample. So you can detect you can measure the non-linearity. You can use peak precipitation so that you can precipitate this kind of antibodies. You can use a heterophile blocker. This is something that is very commonly used in commercial assays nowadays. So for all practical purpose, the result that we get is actually minimally affected by the heterophile antibody. And one of the PDTs in our department is actually doing a dissertation on this particular topic. And the unpublished result, what we found that the actually interference with heterophile antibody, particularly in terms of a patient with a very high titer of rheumatoid factor, is very minimal. So the various techniques that are already employed by the assay system that is used in our lab is possibly sufficient to prevent this kind of interference. But still, with all this, if you suspect that there is still some kind of interference, you can use another platform where the interference may not be there. Now, a very important point about biotin. You all know that the many vitamins have a very high concentration of biotin, and this biotin is basically used with in various kinds of immunoassays where the attachment of the antibody to the solid matrix is done by the combination of or attachment of the reaction between biotin and streptavidin. So the streptavidin is attached to the solid matrix, biotin is attached to the antibody, and it acts like a magnet, and it gets attached to the solid matrix. But when the biotin concentration is very high, or if there is some anti-streptavidin antibody in the patient sample, so that interferes with this kind of attachment, and the antibodies can get dislodged from the solid matrix. So you will get falsely high or falsely low value depending on the whether it's a competitive immunoassay or it's a sandwich immunoassay. Just to give an example, if the biotin concentration in plasma is very high, like it's more than 1500 nanogram per ml, the TSH value may be falsely low, and T4 value may be falsely high in some other system, although in our system, in Immunolite 1000, there is no interference with T4 assay with biotin. So it can mimic, say, Graves' disease or other conditions. So it's very important to be aware of this, and possibly it's better to avoid the biotin for at least 3 days if you suspect this kind of interference. Transport protein variant can also lead to some problems. I've already discussed this. Regarding the signal generation, there can be problem when the lipemia is very high, but in our system, the triglyceride level of up to 3000 does not cause interference. Bilirubin level of up to 20 milligram per deciliter do not cause problem in our assay system. Very high degree of hemolysis also can cause problem. So a sample which is hemolyzed can give rise to falsely low or high result depending on the assay system. So again, These are the factors which interferes with the signal generation. So they interfere in a manner which is independent of the analyte itself. Okay, so I think this is all about immunoassay. Very few words regarding the molecular based system. My disclaimer is that the knowledge regarding this is mostly theoretical, as we do not have this molecular structure based assay system in our lab yet. We hope to get that in near future. But this is mainly for the PDTs for the exam purpose maybe. So one of the structure-based assay is HPLC. HPLC, basically the basic principle is that it uses a stationary solid phase and there is a flowing liquid phase. And the analyte that gets attached to the solid phase depending on their mass. And these can be detected by various methods like luminescence, fluorescence, or various electrochemical methods. And as to give an example, the HPLC worldwide is the most commonly used method for measurements of catecholamines, particularly metanephrine and non-metanephrine. Now, LCMS/MS is further improvement on this particular technique. Here, initially, HPLC is used and the analyte is eluted in the flowing phase, and that is ionized. And there is a successive quadruple chambers through which the this gas or liquid is passed. In this particular example, as it is LCMS/MS, so the liquid is passed through this, and these ionized analytes, they get separated, and there is another chamber where there's collided and the analyte are broken down further to the even smaller molecules. And then again a quadruple mass filter is used, and ultimately they are detected by their charge to mass ratio. So this is a very expensive kind of system, but this is a relatively very accurate system for the measurement of smaller molecules. Okay. There is another kind of assay which is used mainly for proteomics, but not for the steroid hormone. Yes, it is called TOF, or time of flight mass analyzer. This is one of the example of MALDI-TOF, that is matrix assisted laser desorption ionization method. Here, the analyte, it is charged, and depending on their mass and the charge, the time from this injector to the detector, this time of travel is measured, and this is called time of flight, and this varies from one molecule to another, and depending on this time, the amount of signature, the amount of analyte is measured. So a very few practical points regarding this structure-based methods, that LCMS/MS is particularly useful for steroid and related molecules. But it's very important to know that as of now, the normative range may differ from immunoassay. Say, if you can get, say a result, a basal cortisol of 2.5 microgram per deciliter by an LCMS/MS, that may not be low. So please look at the machine by which it is, as a system by which it is measured. But fortunately, the harmonization process between the structure-based system, that is LCMS/MS, and the immunoassays is ongoing. So in near future, possibly we get a similar kind of output from both of these assays. And in future, these methods will be very useful in urinary steroid profiling, which, as you know, can be very helpful in many of the situations like diagnosis of congenital adrenal hyperplasia, diagnosis of adrenocortical carcinoma, so on and so forth. So there are many exciting newer developments that are going on in this field. So I think this is sufficient for today. We have had enough. So let me summarize what have been discussed till now. The immunoassays are most commonly used technique for our day-to-day clinical practice. They are basically broadly classified depending on the analyte antibody interaction and also their detection methods. Assay validation is a very, very important step. For the closed system, many of the assay validation steps are performed by the manufacturer, but it is very, very important to have a very meaningful interpretation of the assay result. Discrepancy between clinical and lab parameters. You should always think of various interferences, but please look at the various pre-analytical, analytic, and post-analytical factors as well. So thank you all for your patient attention. Over to Professor Bantwal for the further proceedings. So I'll stop sharing here.
Thank you, Dr. Rana. That was really wonderful. The way you built up was really good, starting from base till the end. That was really great. I think we have a lot of questions here. Just a second. Start with the first question. There's a question from Dr. Pankaj. What should decide the level of dilution?
Yes, very good question. I think the question is related to prolactin.
Yes.
So as I said, the prolactin level is of up to 22,000. There is no interference in our assay system, and this is possibly true for most recent immunoassay platform. Now, when you suspect hook effect, always recheck with the immunoassay system. But if the tumor size is very large, as you know, the size of tumor prolactinoma, macroprolactinoma, is proportional to the amount of prolactin. So, see, if, as for example, if a tumor size is say 5 or 6 millimeter, and if you dilute the sample, say 1:5 or maximum 1:10, so 1:10 dilution, you can detect up to the prolactin level of 22,20,000 microgram per ml, which is a nanogram per ml, which is a huge amount of amplitude. So I think 1:10 dilution is sufficient. Now you can say, why not go for 1:100 dilution? The problem is that, you know, there is a coefficient of variation and multiple other factors. So even in a very good quality assay, the coefficient of variation, say in the tune of 5 to 6%. And if we use, say, dilution of 1:100, so the error that is, potential error that is there, which is otherwise will not be there if in under undiluted sample or with a low amount of dilution, that will be amplified many folds with a 1:100 dilution. So for all practical purpose, what I tell the different departments also, that please do not dilute it too much. I think 1:10, 1:5 or 1:10 dilution is practicable for most of the clinical situation for the prolactinoma, suspected prolactinoma or skull-based tumor that we see in our day-to-day clinical practice.
Thank you, Dr. Rana. Yeah, as you rightly told, there is a connection between the size of the tumor and the high-dose hook effect. They have found that when the size is more than 4 centimeters, normally this starts happening. Another question from Devaditya, mechanism of low-dose hook effect.
Actually, low-dose hook effect is something that we do not use this terminology nowadays, because with the modern assays, this low-dose kind of hook effect is not seen at all. So in low dose, practically what happens, if the analyte concentration is too low, it is above the level of detection, but below the level of quantitation. So it is below the functional sensitivity of a test. So we recommend that we get a particular value in our assay system. If you look at the deep into the machine output, you get a particular OD value. But from this value, you can back calculate the analyte concentration depending upon the regression curve, but that is not advisable at all, because if it is below the functional sensitivity of a test, the coefficient of variation is very high. is wide and it is not clinically meaningful. So it's always recommended that do not use this value. When it is less than the analytic sensitivity of a particular test, you should not use that result. So this mainly happens because of very low concentration of analyte within the sample.
There's a question once again from Dr. Pankaj. Why Ft4 not preferred? I think you have answered this in pregnancy.
Yes, because of abnormal binding protein, like a very high TPG and their altered bindings. In one-step assay, there is problem I mean, as I've said, that there is, during the equilibrium phase, there is interaction between the free hormone and the antibody that is attached to the matrix and the binding protein itself. So with binding protein abnormality, the free hormone concentration also gets altered.
And another question from Devaditya. I think this has also been answered. Mechanism of two-step wash in neutralizing the high dose hook effect.
Yes. After the first wash, after the first reaction before the analyte, those are washed out, and then you are adding the tagged antibody. So there, the excess amount of analyte that is there, when the tagged antibodies are there, they are no more there in the liquid phase. So they will bind to the solid phase bound analyte. But the problem with the two-step assay is that number one that I have already said, that the closed circuit of these systems that are available nowadays do not allow the washing step. And secondly, if you use it in ELISA technique also, the washing is a very finicky process. So more the number of washes, it will also alter the binding of analyte to the solid phase as well. So you may get falsely low value. So washing is also have its own kind of problem. Okay.
From Dr. Ajay, how do we interpret thyroglobulin levels in the presence of high anti-thyroglobulin levels, antibodies?
Yes. So in presence of high anti-TG antibodies, we usually do not interpret the thyroglobulin value. There we follow up the patient with the anti-TG value itself, which is recommended. But if you wish to change the platform where the anti-TG antibody is not detected, there you can also serially follow up the patient. But what we do, usually we follow up the patient with anti-TG, not with TG for those patients up to.
Right. What's the advantage of one-step over two-step immunoassay in free thyroid hormone assays?
Yeah,
Dr. Akhil.
Again, with the free thyroid hormone assay, in one-step method, the analog that is there, the tagged analog, that has to be developed in such a way that in one hand it binds to a tagging material. On the other hand, it's designed such a way that it do not bind to the binding protein. So this is a kind of very difficult kind of molecular interaction. So, but this the problem with the washing is, as I've already said, that it can dislodge the the analyte or tagged antibody that is bound to the solid phase. So that's the problem with washing. But the advantage is that is easier to develop because of less amount of molecular alteration, structural alteration that need to be done to a very small steroid or steroid-like molecules.
I think that's all we have questions. Okay, let me have the last question. What do you think? Will LCMS replace the immunoassays? Because LCMS are very good for smaller molecules like steroids, and you can do so many things at one step. There's no interferences, say dexamethasone or hydrocortisones you can measure. So the management could also start differing. Will it replace the CLIA or something like that?
I think so, sir. Particularly for the steroid assays and other small molecular assays, possibly it will replace the immunoassays in near future. I hope the system will get more and more cheaper. But for the peptide assay, I think the role of immunoassay is still there, because the kind of breaking down of the molecules and their measurements, they are not that well developed till now with LCMS. MS maybe tough kind of assay where Nalditov or Senlitov, we can use do the proteomics when we want to use a large number of proteins together. But for assaying a particular single molecule, which is more of a practical use in our peptide assays, I think the role of immunoassay will be still there, at least in the near future.
Dr. Rana, that was a really great lecture by you. Over to Dr. Nilanjan for the final words. Nilanjan still there? Otherwise, I will hand it over to Dr. Niladri Das. Dr. Niladri, you're there? Okay, then I will
I think he's there. I think he has joined. I think. Dr. Niladri, I think you have unmuted yourself, but your voice is not audible yet. We can see the Endocrine Society of Bengal here.
Dr. Niladri is there. Your voice is not audible. Okay, if there is a problem, I think I'm sure we have had a great day of lecture by Dr. Rana on what an endocrinologist should learn. That is a minimum thing, bare minimum, what you should know about assays. And that was actually dealt very well by Dr. Rana.
Hello, sir.
Him. Yeah.
Hello, sir. I'm audible now.
Yes.
Sir, thank you,
but you are
sir.
audible.
We are
Yeah.
now at the end of this webinar. I would take a moment to announce our next webinar, which is scheduled on 16th of July by Dr. Kalyan Kumar Gangopadhyay as a chairperson and Dr. Rimesh Paul as a speaker of the next session. And the topic is diabetes and the bone. Till then, thank you to all participants. And
And you're muted yourself. Yeah.
Sure.
That's fine. Okay. Goodbye.
Yeah. Thank you. Goodbye. Goodbye.
Goodbye. Yeah.